and welcome to the Home of Medicine podcast, a podcast in association with the European Federation of Internal Medicine. I'm Dr. Amie Burbridge, a consultant working in acute and general medicine in the United Kingdom. And over to you, Ben.
Hi, my name's Ben Lovell. I'm a consultant also in acute and general medicine, and I work in central London.
Fantastic. Thank you so much for joining me again today, Ben.
Pleasure.
And also thank you to all of our listeners. The podcast has been released now for a couple of weeks and we've had fantastic feedback. So thank you to everybody out there who's listening and helping us grow this podcast. So Ben, over to you.
Are you ready for a case?
Always.
Okay, so my first disclaimer is a lot of this case was driven and run by my excellent registrar. And I came along and said, can I use this as a teach kit afterwards? So just in case she listens and say, hey, he's stealing my thunder, I give this all to you. You were an absolute hero and a star. So this is a patient who came in on the medical take with an unknown name and an unknown age. Picked up at King's Cross, big central London train station, acting strangely by the police. So was conveyed to a place of safety, which was our A&E department. And end of the bed looked to be in his mid-30s. Okay. But we weren't able to get a name, and he was obviously very confused, very agitated, quite aggressively disturbed behaviour. The police brought him in, and A&E saw him first of all, and they did manage to get some baseline observations, and they managed to get some blood tests off and a cannula in. But then, unfortunately, the patient's mental state deteriorated, and they referred him to the medics because they went through his bag to try and work out if he had any ID, and they found in his bag multiple packets of olanzapine, many of which were empty, and also some very concerning things such as knives and other weapons, which they briskly confiscated. And in A&E, they did manage to elicit from him that he does have some kind of mental health background, probably schizophrenia, but it wasn't quite clear. So they referred to medics saying, look, we think this could be a psychotic episode in someone who's known to have mental health problems, but we have a lot of empty olanzapine here. And we've looked at tox base and we're concerned, we don't know, but we're concerned he may have taken them as an overdose. He might need a period of medical monitoring. We don't think that's safe in our psychiatric assessment unit. And A&E really did try to control his agitation with multiple doses of benzodiazepines. They'd given him 2 milligrams of lorazepam, then another 2 milligrams of lorazepam, but he still had to have security guards sort of observing him and keeping him safe. So there you go, referred to a medic. Oh, and also his blood tests came back, which showed a CK of 40,000. So they've said, oh, look, this is rhabdo, so he needs a medical admission. We can't send him to the psychiatrist in this state. So that was a referral to the med-reg. If I pause there, do you mind just going through what you're thinking and how this should be managed from here on out, even if no diagnosis, but sort of what are the avenues open?
Okay, so we've got a gentleman in his mid-30s, roughly around about, don't know his name, don't know much about him. He was found acting strangely, agitated, aggressive, not really responding to benzodiazepines. In his bag, you found lots of olanzapine or empty packets of olanzapine, knives and weapons. And the theory was that he was quite psychotic. So first of all, the first thing I wanted to do, and it sounds like was actually done, was ensure that he's in a place of safety and that he's being well looked after in a nice, calm, soothing environment, which is very challenging in the emergency department with security guards. And it's one of those situations where you need security guards there to protect the patient from himself and also to protect the staff and the other patients in ED. But sometimes the presence of security can also escalate the situation itself. And I found myself in these situations before, and you're sort of between a rock and a hard place because you really don't know what's best for everybody. So he's walking, so he's quite agitated. So I know that his airway's fine. You said that you got some observations on him. What are they?
Okay, temperature 37.4.
Yeah.
Heart rate 130.
Wow.
Sinus. Blood pressure 150/97. And he thereafter refused any attempts at taking observations.
Okay. No. Okay. So he's got a very subtle low-grade pyrexia. He's obviously tachycardic and he's hypertensive. So I guess when I ever have a patient like this, my first approach is to go back to basics and do an A to E assessment. Because I don't really know what I'm working with. So his airway's patent, his breathing okay. Is he going to let me examine him?
You could try. And I think that's sort of a subtle point there about how you manage these patients, is who goes to make the assessment. He has sort of struck out. But at the time of referral, he had 4 security guards with him, and one of the security guards had sustained quite a nasty laceration from the patient. So I think the troubling thing is we need to medically assess this patient, but I don't think my team will be safe at present. He's hurt a member of the team already, and he may hurt himself or someone else. So obviously, this is not a situation where you send the FY1 toddling off with a medical clerking. Who should see this patient? I guess is the question, and how. So you could try and use your communication skills, try and use your de-escalation skills, and get an assessment of the patient. But it really is a judgment call about what situation am I putting myself in and how we do that, which is really tough.
It is, and I've certainly been in many situations like this, when sometimes I've been able to de-escalate the situation and other times I haven't. And it's exceptionally challenging. And I think in these situations, it's really important to always have somebody with you.
Absolutely.
You don't go in alone.
Yeah. And when someone is in the grip of maybe an emotional crisis, for example, a mood disorder or some kind of psychological crisis in terms of suicidality or a personality disorder, then I find that you often can, if you put a bit of time and effort in, de-escalate to get what needs to be done. But when a patient is psychotic, they are not in the room with you in any real sense. They are not in the same reality as you, and they often view your attempts at de-escalation with suspicion and paranoia, saying, what are they trying to do? What's going on here? They're trying to trick me or something. And sometimes they just can't be de-escalated. And knowing when your efforts are going to come to naught is sometimes a useful thing to know before you go into the room.
At what stage would you use rapid tranquilization?
Probably at this stage. If someone has hurt themselves, has hurt a patient, that's when I would go to our rapid tranquilization protocol, which, to be fair, A&E had done. Ours is to try lorazepam. Well, actually, the phraseology of the rapid tranquilization is offer the patient oral medication in the first instance, and if not, then move on to IM. And I think it mentions lorazepam, it mentions promethazine, which is an antihistamine, which has some drowsy sedating effects. And then you can try moving on to things like olanzapine or haloperidol. Obviously, you wouldn't give olanzapine to this guy who may have taken too much already. I often find in patients like this, the rapid part of the tranquilization doesn't seem to work because they're so resistant to the medication, because they're so agitated. They're in such a hyperadrenergic state, sympathetic arousal, tachycardic, a lot of adrenaline sloshing around. And sometimes you can give what I think are really impressive boluses of benzos and the patient's still fighting. And then that's when I start getting a bit nervous, because I start wondering, are they all going to hit him with a crash and then he's going to have basically a general anesthetic because all of a sudden they'll have 9 milligrams of Loraz on board? Or do we have to think of another way of maintaining safety for patients and staff now if our rapid tranq protocol isn't working?
And I mean, I guess a good approach here would be to contact the psychiatric team on call. If you have a liaison psychiatry team, because they often have very useful information about rapid tranquilization in this sort of setting. Okay, so now the sort of things that I'd want to find out about was, is there been any cocaine on usage, any amphetamines, any ecstasy that are causing this hyperadrenergic state? You mentioned that he'd taken or possibly taken olanzapine. So regarding the rapid tranquilization, using another typical or atypical antipsychotic is probably not the best usage of medication. So I'd probably want to get some advice as well from the liaison psychiatric team, who are probably more used to dealing with this than I would be. You mentioned that we know he's got a mild pyrexia. He's got this very, very high CK. So the raised creatine kinase can be due to a number of situations. So it's normally indicative that we've got huge amounts of muscle activity. or muscle death, for example, in a myocardial infarction. Has this man had a cocaine-induced vasospasm, which has led to very high levels of creatine kinase? Maybe, I don't know. Let's try and get an ECG. That's a possibility. Secondly, I'd want to be thinking about, has he had seizure activity? So seizure activity could raise his creatine kinase. But actually, the thing that I'm really conscious that this could be is something like neuroleptic malignant syndrome. With a mild pyrexia, the tachycardia, the hypertension, and the fact that he's got empty packets of olanzapine, are we actually looking at a psychiatric emergency such as neuroleptic malignant syndrome?
So you came to that conclusion a lot quicker than I did in real time, which is an excellent conclusion to make. So I was looking at a guy who was in a very profound aggressive disturbed delirium or aggressive behavior disturbance, whatever you want to call it. And I thought, yeah, he's got a raging tachycardia, he's hypertensive, he's saturated in adrenaline, he's sympathetic arousal, he's got a bit of muscle breakdown because of that, really. And you do see that, don't you? Raised and a bit of rhabdo in a context of like that. And I thought we just need to get him safely sedated, get an IV line in, examine him from head to toe to make sure there's no, infection or anything else, to scan his head, that sort of thing, any focal neurology, and give him a bit of fluid. And it was actually my registrar who came up with the NMS, the neuroleptic malignant syndrome, which he came up with just then, which made me sort of think, that's a really good point, actually. And I always, to be honest, I always have struggled to remember the NMS and how to differentiate it from serotonin syndrome.
Yes.
And the only way I can keep it separate in my head is, look, Ben, serotonin syndrome comes if you take SSRIs, and NMS comes if you take dopamine modulators like olanzapine. I know there are more subtle things, and I have looked it up before this podcast, but it's something that I do have to go back to and look up. Because I don't carry that information around in my head. Everybody has a little blank zone, and I'm not ashamed to say that that's mine in everyday clinical medicine. But I thought it was a really good thought, because we got this CK, the white cell count was slightly elevated at 14, the CRP was 17, but I was willing to put them down to his his aggressive state, and sort of like, yeah, he can have some inflammation due to what's going on. And it was my registrar who managed to sedate him. And do you know how she did it?
I wouldn't know how to do this. Go on then.
She actually called ITU and rapidly had a rapid sequence induction and was intubated in ED.
Gosh.
And I said to her, how on earth did you, not did you sell this to ITU, but ITU don't come around and do that very often, because it's not a safe procedure to do on an unfasted, unknown, unworked up patient. And she said, I just said to them, look, this guy at this point, he'd had a staggering amount of benzos on board. I think 5 or maybe even 10 of haloperidol, and he was showing no signs. There was like 6 security guards pinning a limb each. And she said, I'm worried about his airway. And it's very true, because I think when you look at patients who do have aggressive disturbed delirium, aggressive behavioral disturbance, we all think about the dramatic phase of when they're going to hurt themselves, which is when they're flinging themselves around and they're risk themselves and others. And we think we just need to safely sedate them. But in fact, the danger comes after the sedation. So they get sedated, they drift off, or they become very drowsy. Everyone goes, phew, okay, security drift away, medical personnel drift away. And then you can come back to the patient 45 minutes later and find them with no respiratory effort at all. Basically, you are giving them a GA in a completely unsafe situation with an unguarded airway. And that's why our rapid trank really makes it very clear in our protocols is the story does not end once the patient is sedated. That's when the hypervigilance from medical staff begins. And you have to make sure that someone is one-to-one in them and doing regular observations at least every 15 minutes, because that's when their GCS drops to 7 or 8 and they lose their airway, or bromate and aspirate, and all sorts of things happen. Also, with the very best of intentions, staff members may be holding patients down to protect themselves from injury, protect the patient injury, and actually lead to airway compromise or other damage in that way, but purely by trying to keep everybody safe. But the patient may not be able to express that they can't breathe properly, and there have been cases of that as well. So it's actually a very tricky thing to get right. And the rapid tranquilization, which is really mostly about the pharmacopoeia of the situation, needs to capture the danger for the patient, be it before and after they get tranquilized, so to speak. So anyway, she said to ITU, and ITU very obligingly came down, and God knows how they got close enough to do it, but they sedated and they intubated the patient. And that was when my registrar was able to examine them and note the patient was hyper-reflexive, and the patient had sustained clonus in their ankles bilaterally. And in retrospect, the patient's activity before tranquilization was akathisia. They couldn't sit still. They were throwing things around, moving themselves around, absolutely couldn't be still for a second. So I know that you normally see hyperpyrexia with NMS of like 40 degrees or more, and this patient was only 37.4, but they ticked a lot of other boxes. And so that's how that diagnosis came about. And she said to ITU, said to me, I think this is a patient with NMS. They have an organic pathology driving this state. This is not pure psychosis in and of itself. And the patient was taken to intensive care and had a good outcome to discharge, and was actually treated with IV dantrolene in ITU, which is a muscle relaxant, and seemed to do quite well.
These, I think what we need to really remember about these cases is I have been involved in quite a few situations. Some have had good outcomes, some not so good outcomes. And actually, the patient is very stressed, very agitated, very hypervigilant, which then actually translates to the staff. Yes. And the staff become incredibly stressed, hypervigilant, and hyperadrenergic as well. Yeah. And I'm not saying we need to utilise rapid tranquilization on the staff. However, I really think the value of debrief is important here, because what often happens in situations like this is, like you say, we've got the individual, he's been calmed down, settled, and we just walk away and carry on with the next patient. But actually, we've got huge amounts of adrenaline surging around, and we've just, this has taken the noise, and this has taken often over an hour, even longer sometimes, to get to this situation. And it's about, as members of staff, taking a step away from the situation, taking some deep breaths and having a debrief about what happened in the situation, what you did well, and what maybe you could do differently next time.
Yeah. Yes. Just checking in and saying, are you okay?
Yeah.
I suppose in that debrief, it ought to include the security, which I've never seen before.
Yes.
One of them has been hurt, has been harmed,
Yeah.
And he's going to go home tonight and know he was attacked by a patient, and he's got a big lack on his face. And I've never seen a big MDT debrief that includes them before. Maybe other people have, and they probably definitely should, because he's the one person who actually sustained a real injury.
I completely agree. We sort of go into our own little medical fraternity, I guess, and you sort of go into the staff room, but actually it's the security who've really struggled. And we did have a quite similar situation in our medical decisions unit when we did actually have a chat to the security team afterwards. And ever since then, I found that my relationship with the security team is really good, because we've had that conversation. We've sort of had that, I guess, that we were all involved in that really difficult situation. And I think that's where the benefit of Swartz rounds comes in, actually. Do you have those in your trust? Yeah. So a Swartz round is like for people who don't really know what they are, it's like anybody in the whole hospital can attend, and it's 1 hour where you reflect and debrief about situations that you've been exposed to. And we've had quite a lot of success with them at work, because people have attended who you would never even normally connect with, and I think they've been really valuable, including the security team, people who work in the coffee shop at work, in the shops. They also see really awful things. And I think we really need to start reaching out to everybody, actually.
Who runs them?
So in my trust, it's actually me, because it was something that I felt would be really valuable, along with a chaplaincy, because we sort of had we both of us had a desire to reach out to other staff, and but I mean, anybody can introduce them to wherever you work. It can be any member of staff. You contact the Point of Care Foundation and you have training. It's quite a lot of work, but it's really, really, really beneficial.
Okay, so you did have a bit of training for it.
Yes, absolutely. It's a few days, actually.
considering, I mean, where we work is so diverse and multicultural, I don't know if the chaplaincy would be the right way forward for us, because we have 50 religions, but I think it's a good idea to have something that is a true MDT. When people think MDT, I think we think doctors, nurses, and allied healthcare professionals, but there are hundreds of other people in the hospital who are affected on a day-to-day basis and aren't included or invited. I think it's an interesting idea.
And certainly throughout COVID, the chaplaincy were amazing. And the charity, we've got a really good charity as well. And it's, pre-COVID, I probably wouldn't have associated, that type of support that they could give us, but definitely during COVID, they were both incredible. And that support's continued now, which has been a really interesting outcome, I guess. Really interesting case you've brought there.
Yeah. I thought it was one thing and it turned out to be a second thing, and it was effectively treated. And also, I guess it just goes to show that, you've got to be open to the ideas and input from everyone.
I haven't got a clue. Am I missing something? I know I often say to myself and to those around me, am I missing something here? What has happened that I've completely missed? And often it's maybe one little piece of information and that helps to clinch the diagnosis. With neuroleptic malignant syndrome, it's often an awareness, and also you've seen a previous case of it. Because it's like you, I can read about it, remember it, and the next day I'm like, I can't remember what the difference is between the two. It's the same with the coagulation cascade.
No, I'm giving that up for dead. Not going to happen. But you're right, having a real case anchors it in your memory. And that's why people always said to, as a medical student, once you've seen an interesting case, now go home tonight and read about this case, because you'll always remember it, because it'll be tied to this patient in your long-term memory. And it's so true.
Yeah. The problem with that is that you then think every patient who then comes in who's acting strangely with a raised CK is going to be neuroleptic malignant syndrome.
Recent case bias. It's
exactly.
A well-known cognitive bias.
Absolutely. And I'm 100% guilty of that. And I'll be like, I saw this yesterday. It's got to be neuroleptic malignant syndrome. Yes, which it could be, but then it stops you from again thinking of the wider picture, doesn't it?
Yeah. I mean, I think it's okay to just quickly say to yourself or to your team, are we sure this isn't NMS? Quick scan. Yeah, we're sure. Okay, this is something else. But I do know people, and I'm sure I do it myself, who had one big case which has made such an impact that they always screen for this case moving forward. Has every shoulder pain got a hidden sarcoma or something like that? And I think it is a really impactful way of how doctors, any clinicians operate moving forward is one big impactful case. But as long as it's not leading you to do unnecessary tests on the patient, then it doesn't translate, I think, into too much harms in the real world.
It's that typical hindsight bias, isn't it? That, in hindsight, I wish I would have done this differently. It often happens with D-dimer. That D-dimer that you didn't do and the patient ended up with a PE. I've certainly seen huge numbers of D-dimers requested when that PE's been missed. Any thoughts about the D-dimer?
Many. I could write a book about it.
Please do.
Yeah, D-dimers I find are like they're strange attractors, as physicians would call them. They drag into chaos, and sometimes they're insanely useful. And I've heard A&E departments I've worked in saying, medics are always moaning at us because they're always saying, oh, you did a D-dimer unnecessarily. And then if we don't do one, they go, why didn't you do a D-dimer? They never know what you want. And I guess the moral is the D-dimer should only be requested with a bit of thought beforehand. It should never be a routine tick like, chest pain bloods or breathlessness bloods, that sort of thing. It should only be requested when clinically appropriate based on pre-test probability. And I think that's really hard to get your head around because it's sort of counterintuitive. It's sort of hard to learn. And very often I'm handed over a D-dimer I did not want, and now I do not know how to interpret. And it takes a lot of guts to ignore it sometimes. If the patient has no signs or symptoms of a venous thromboembolism, and I'm going to put that D-dimer of 1,000 to one side, I cannot explain it, but a D-dimer alone does not diagnose a clot anywhere. But it's hard to do. And sometimes you go, what if?
I know. And what's interesting as well, something that you said, chest pain bloods, breathlessness bloods, is again something that we do. But again, that stops us thinking, because chest pain bloods, okay, troponin, D-dimer, CK, but actually, do they need them? They've come in with chest pain. Let's take a really good history. And actually, you've ruled out all of those conditions that you're testing for with the bloods.
I guess it's because we want to have the bloods at the time of assessment, don't we?
Yeah.
We get very upset as medics if someone hadn't been bled. So we can't live in a world where we see the patient first, then we carefully choose intellectually out the bloods we want, because the patient's 2 hours behind where they should be at that point. And so we have to really learn in acute medicine how to screen the bloods we've been handed, requested by people doing their absolute best, at the front door to be, to help the patient and to help the system. But it's hard. Sometimes you get people with troponins I never wanted in the first place. Someone's coming with a crashing septus and AKI, and now I've got a high troponin, and I've got to somehow stop the bandwagon of echoes and cardiology reviews, because it's okay to have a high troponin in this context. So it's about knowing, I think, when to allow very abnormal blood results contextually, which I think is quite experiential. You sort of learn it on the job, and maybe by watching other people do it.
Yeah, it's really challenging, and it's something that I'm still learning, because if it takes a very confident decision, I think, to ignore the troponin, to ignore the D-dimer, to ignore that CRP, that ESR.
There is no section in a medical textbook anywhere that's called blood tests you can safely ignore in certain contexts, because you can't do that, because people will start missing. So it's all to do. You have to just apply patient-specific clinical reasoning, and it's hard to teach that didactically. You have to sort of get a feeling for it.
And I find it very difficult to do that when you've got 40 patients to see.
Yeah.
And it's really busy, and then you've got to apply that patient-specific clinical reasoning, and often you've got a queue of people waiting to talk to you, so other members of staff, and you're trying to make these really complicated decisions in exceptionally noisy, very challenging environment. And if you think about human factors, how can we making some very challenging decisions? It's noisy, we're hungry, we might need the toilets. It's really hard to do that. And it's how can we change our working environment to enable us to make those decisions better?
Yes, and you can certainly see why some people get into a place where they say, the easiest course of action right now is just request a CTPA. Just do it.
Exactly.
Just do this. Yeah, just get the echo, get the cardiologist to see. Rather than saying, okay, on balance, I don't think we need to go down this road. And it's no good, really, because you don't expose patients to invasive tests or radiation or contrast or prolonged stays in hospitals that they do not need. But the NHS machine that we work in demands rapid decision-making, which is not always our best decision-making, and can sometimes be more defensive than sort of proactive. And, you can't criticize too harshly people who are just trying to take a path of least resistance in order to see all of the patients in terms of distributively giving good care rather than giving excellent care on an individual basis. And that's a sort of dilemma we work in acute medicine a lot of the time.
Yeah, absolutely. I'd love to spend 30, 40 minutes with every patient.
Oh, me too, yeah. Find out who they are. Who are you? Where'd you come from? What's your life? Who do you know?
I know, exactly. I love finding about their pets, general what we've been doing at the weekend. But actually because I think if you develop that relationship with a patient, it actually really helps with making that diagnosis. But actually in such a time limited area, you just can't do it. It's really challenging.
My ideal ward round would be, maybe I saw 5 patients and I had an hour to do it in, and I could sit down at the bedside and say, tell me about you, rather than what I have got now, which is about 30 patients in 2 hours. So it's by the seat of your pants. So that would be a really interesting ward round. Somebody must be doing it somewhere, those sort of ward rounds. I think the palliative care physicians get to do those sort of ward rounds, maybe.
Maybe we chose the wrong specialty.
Let's not open that kind of worms.
No, I absolutely love my specialty, but sometimes I would like to spend more time with my patients, actually. Okay, so 3 learning points, Ben, from that case and what we've talked about today. From me or from you? From me. Oh, well, okay. So
I'll give you 3 learning points. Got it.
You give me 3. What are your 10? Oh, right. Let's start this again, Amy. Right. Okay. So what are your takeaway messages from this case?
Okay, I'll do that. So my takeaway messages are: rapid tranquilization is fraught with hidden dangers. And rapid tranquilization does not end when the patient is sedated. That's when you have to suddenly be very, very alert. And this is when things could go horribly wrong for your patient. So make sure that you are continuing to care for the patient and don't let that whole team diffuse away, leaving the patient unattended with what could be some pretty big doses of benzos on board and an unguarded airway. Mm-hmm. My second learning point would be, well, I guess search the bags of patients who come in without an identity, because I hate to think if we had got hold of one of those knives, or if we hadn't spotted the olanzapine issue. So I think you are on your rights in terms of working out how to keep your patients safe, and is have a look through their pockets and see if we can work out who this human being is and how we can help them. Mm-hmm. And I guess the third learning point would be, I don't want to say think NMS, but I would just say, let me say it this way. Invite other opinions from the group, because some other people may have an idea that you've missed. And in this case, someone could say, I wonder if this could be neuroleptic malignant syndrome, which I hadn't considered. I thought this was just, inverted commas, someone who was in the grip of a psychotic episode having a hyperadrenergic state. Mm-hmm. So welcome opinions for other people. Don't think hierarchical. Don't think that more junior people can't actually make the suggestion which changes management. That'll be my point.
Yeah, and I've had some cracking diagnoses made by junior members of my team, and I'm like, wow, that's amazing, and they're spot on. I'm like, and then they leave acute medicine and go and do something else, and it really upsets me. But yeah, absolutely, I completely agree. It was a really interesting case. I think as well, when you've got a blood test like a CK of 40,000, and we go, it must be rhabdomyolysis, but actually it could be other things as well. So really think about creatine kinase, go back to basics. We know that it comes from muscle breakdown. What muscles might be breaking down that are going to cause that elevated CK, and dip the urine as well.
Yeah.
To see if there's any myoglobin in there. Yeah. Fantastic. Thank you very much, Ben, for joining me on that really interesting case.
Thank you for having me.
Thank you very much to all our listeners out there of the Home of Medicine podcast. If you want to get in touch, please tweet at Amie Burbridge and listen out for some new episodes. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.